Yeah, ocular oncology, oculoplasty, cornea specialization, vitreoretinal specialization, neuro-ophthalmology, glaucoma specialist. You have strabismus ophthalmology, pediatric ophthalmology, and so on and so on. And there is a community ophthalmology is there. So there is a vast ocean ophthalmology, and hence it requires a very extreme degree of knowledge and education in that field for a normal person to work. But still, we should have some basic idea of ophthalmology. The reason for that is the principle of non-manifestance. That is, you should not do harm to any person. So, any patient who approaches in our day-to-day OPD, you should be, I is one of the part of Ashtasthana Pariksha, and hence being a physician and while doing the Hippocrates oath and even the Charakas oaths that which we practice, we should be able to diagnose the patient Rogamadav Pariksheta. We should be able to diagnose the patient that from the minimal signs that is exhibiting in the eyes, so that at least we will not harm him by rightly diagnosing the patient. And if at all, even if we cannot do, we can refer the patient to some ophthalmologist and then make him better. So, principle of Atura Rakshatvam, that is the main motto. That is why this topic has been selected for everyone to know the basics of what to do in an ophthalmology and what are the possible things that is at present existing as part of a clinician, so that we can understand if or we can prescribe to the patient who is coming for with some eye complaints. So we all know that the famous the sloka that has been told by Vagbhatacharya, Chakshu Rakshayam Sarvakalam Manushehi Yatnah Kartavyo Jivido Yavadicha Tulya Loko Ayam Tulya Radrim Divanam Pumsanam Andanam Vidyamana Epi. So we should be inclined in such a manner that any patient, where any specialty, even if we are practicing, we should examine the eyes as one part to make it very sure that because of our prescription or because of our negligence, the patient does not lose his precious eyesight. Okay. So this has been made a general disclaimer. All the pictures that has been used has been sourced from the internet, and you can photo search them from the search engines to get the details from its parent side. So basic anatomy and physiology. I think that Dr. Sri Kumar had already gone through the basics of anatomy and physiology in the last class. Because if I need to describe any of the examinations and the findings that you get, you should have a basic idea of what is eye, what is there in the eye. So I'll just brief it in a very small slides. So you can see the position of eye. It is located in the orbital space, which is surrounded by the bone orbital area, and it is actually in a cushion. That is the area. There is fatty tissue that is there in the orbital space, which acts as a cushion to the eye to prevent any kind of direct traumas or shakes to the eye. If we see the anatomy of eye in a very brief area, you can see from the anterior to the posterior. I'm not going into the every detail of the eye, the three codes and everything, because that has all been discussed last class. From the anterior to the posterior, that is, you can see from the anterior to the posterior, you can see the cornea, that is which is the initial starting. This area is the cornea, and then you can see the iris. That is this green area is the iris. You can see the lens, then you can see the vitreous, then you can see the retina, then you can see the optic disc, the optic nerve, and this optic nerve goes back as the optic chiasma, optic tract, and then which goes into the occipital area. So on a very basic language, you can say that the eye comprises of the functional anatomy of eye comprises of an area starting from the cornea, then it comes to the lens, then it comes to the vitreous, then it comes to the retina, then it comes to the optic nerve, which goes as optic tract, and which comes finally as the occipital cortex, the visual area. So this is the grossly the idea that how a functional anatomy works. So you can see in this picture that the object that you see with the eye is being made inverted in the retina because of the nature of the lens. That is, any object which is on the above of the eye get focused on the below of the eye and in the retina, and any object which is below will be focused on the above area. This is how the objects are focused. And now, when this is an inverted image, how do we see the objects upright? That is the peculiarity that the brain shows. That is, you can see the next picture, the stereoscopic vision. That is, what the brain does is that the images from the left and the right eye will be focused, that is focused independently, will be fused together into one object which is having a three-dimensional nature. That is, it will be having a length, it will be having a breadth, and it will be having a height. That is, you can see this three-dimensional nature here. You can see this three-dimensional nature here. See, it will be having a breadth, it will be having a height, and it will be having a length. So all these three will be made together by the fusion reactions of the brain, which is called as the stereoscopic vision. So for getting a stereoscopic vision, you should have both your eyes functioning together. This is very important while considering regarding the ophthalmology. You can check yourself. You close one of your eyes and then see an object which you have not seen earlier. You can see that the depth perception of the object is difficult. You can see only the length and the height of the object. It's very difficult to see the width of the object. So if you close one of your eyes and then start seeing the object, you will not be able to feel the width of the object. That is, you will not be able to feel the depth perception of the object. So whenever a patient comes to you with only one eye, or with any eye which is there is the other eye is diseased considerably so that the vision is very low, or he has been made medically the other eye is made blind. I cannot say the blind, but the diminished vision has been made by some sort of mydriatic drops. You should be very careful that he will have a loss of stereoscopic vision, and hence you should not allow him to drive the vehicles, because while driving the vehicles you should be able to understand at what distance from you the object is and how long the object is, that is how width the object has. This cannot be felt while if you are using only one eye or if there is no stereoscopic vision. So this should be remembered in a clinical angle. Okay. Now this is the retina, which has been discussed last day. On a very broad angle, there are two main important parts in a retina. One is an optic nerve, and second is a foveal area or the macular area in which fovea and foveola exist. Okay, now you can see that you can consider this as a neurovascular tissue. That is, there is nerves and there are blood vessels for the nerves to function. If you see the below picture, you can see here the nerve fibers has a peculiar fashion that they are almost like in a combing fashion from the inferior, from the temporal part to the nasal part, and they do go in a combing fashion. You can see the fashion that is there, and you can see how the arrangement of ONH is optical nerve head. So you can see how these fibers are arranged in the optical nerve fibers. Now I would like to draw attention to the fact of the macular area. You can see the macular area. See the macular area fibers. That is, this is the macular area. This is the macular. Hello, doctor. Hello. Hello. Hello, doctor. Maybe. All other attendees, please mute your audio. Hello. Hello. Hello, doctor. Am I audible? Yeah, now you're audible, sir. Hello. Yeah. Yeah. Okay. Okay. We have, I was saying that with the inferior area, you should be knowledges that the inferior area will first go, then the nasal part, then the superior part, and then the temporal part. So this kind of knowledge is very important, and the distribution of nerve fibers is very important while dealing with the clinical area. Okay. Now, this is in a gross sense. This is a picture that is being there. I will not go into the details of all these. You can see the slides. What I want to focus on this area is that you see the first one, that is, you can see the entire, you can see the left eye, the vision, the right eye vision. From the left eye, it is crossing over. That is, few parts of left eye is being crossed over to the right eye, right side of the brain, and few fibers of the left eye is crossed over to the left side of the brain. So this is how from both eyes the vision is, the neural fibers are being transmitted to the optic nerve, the optic cortex, visual cortex. Now, and in each area, this picture is itself self-describing. In each area, whenever there is a lesion, you can see where there is what kind of defects it will be producing in the vision. You can see, suppose if a patient comes to you with 5, that is homonomous hemianopia on the right side, you can see that the vision will be affected in the area of 5. That is, it will be area in the lateral geniculate body. The vision, there will be lesion in the lateral geniculate body. Or if the patient comes to you with a lesion only in the macular area, only in the macular area, there will be central scotoma. There will be central scotoma. You can see the central scotoma. That is, visual field will be defective only in the central area. So we have seen in Ayurveda, there is Pashyatyasyam Anasikam, right? Pashyatyasyam, you can see the face and the surrounding area, but Anasikam, you cannot see the nose. So such areas of central scotomata will be having a defect, especially in the macular area. Now, if you see the third area, the third part, you can see the third part, the entire optic nerve is being damaged. You can see that the entire eye, there will be a monoocular loss of the vision. So based upon these, because you can see this clinically, especially the monoocular loss of vision, then and homonomous hemianopia, you can see very clearly. And the first one, peripheral loss. The peripheral loss will be happening as we have discussed in the earlier slide. See, the peripheral loss will be happening when the macular area is being preserved. See, the macular area is being preserved, and all the other areas, that is superior arcuate, inferior arcuate, and inferior radiating and superior radiating fibers are being damaged. In such area, you will have a peripheral loss of vision, and which is being usually shown in the glaucoma. So you should have an idea regarding what kind of vision loss will be there based upon the anatomical site of the lesion. The quadrantanopia is usually we don't come encounter with such kind of diseases in routine clinical practice, but they are not to be excluded. That has to be also kept in knowledge. Okay. So I hope you have got an idea regarding what is stereoscopic vision. Now, the basic function of eye is vision. That is why we have been told as if the eye is being disturbed, then the entire world will be turned into a black. Okay. So the visual acuity can be tested at any of our normal OPD settings using a Snellen's vision chart, which has been described in this. Based upon the language, you can use any one of these, and the in between is a Landau's E chart, which is used for illiterates, because you cannot ask them to read in any of the languages. So you ask in which direction the E is being directed, and ask them to point it out, and you can record their visual acuity. What you have to do is you have to make a person sit in front of this chart at a distance of 6 meters. That is the most important point. 6 meters, and then you ask the person to read with individually with each eye. So there is a very easy tool that is available online. You can call it as a LogsNet occluder that you can use for recording with individual eye. You can see that one eye is closed and other eye is open. So you can use this, and then you can keep on the eye, and whichever eye you want to open, you just raise this lid so that area will get open, and you can ask the person to read, so that you can record the individual eye. Now, once the eye has been recorded for a distant vision, now if the person's visual acuity is before, let me have it tell a point how we record the visual acuity. We record the visual acuity by the usage of certain standard numbers against the distance that has been used for testing the visual acuity. That is, if you see any of the ophthalmological prescriptions, you can see that a number which has been called as 660 or 66 or 612. So ideally, a person should have 6 vision, that is 6/6 vision, and the more the denominator, that is 612, 618, 624, 660, there the lesser his visual acuity is. Remember, the more the denominator, the lesser the visual acuity is. That is, if a person is able to read the last line, that is, see in this picture, if you see the last line, if a person is able to read the last line, this means that at a distance of 6 meters, it means that the person is having an ideal normal vision. And if a person is not able to, is only able to read, say, suppose at 660, it means that the person has a severe loss of vision. This should be remembered. Now, what is the basics of this? This has been made in this small chart. That is, all the objects that has been the letters that has been has been described on the Snellen's chart, they project totally an angle of 5 arc minute, which is individually a sum of 1 plus 5 boxes of number. That is, 1 boxes of number stacked into 5. So 5 boxes of number, making a total of 5 arc minute onto the eye. So you can see the biggest letter will also give a 5 minute of arc on the eye. The smallest letter will also give a 5 minute arc on the eye. So when you say that a person's visual acuity is 6/6, it means that the letter which has been shown on the lowest line, which intends an angle of 5 arc minute, can be read at a distance of 6 meters. If you say that the letter which if a person reads only, say, 624, it means that a normal person who can read this letter at a distance of 6 meters, but for this person, he can read, a normal person can read this letter at a distance of 24 meters, but for this person, he can read it only at 6 meters. So you see the difference. A person who can read a letter which is at a distance of 24 meters, For this person, he can read it only at 6 meters. That means you should bring the objects as close as possible to the person so that he can read it. And hence the 660, what does that mean? That a person who can see this letter at a distance of 60 meters, this person can read only it at a distance of 6 meters. So the lesser the denominator, the better the visual acuity of the person. Now, this is for the distant vision. Now, similarly, we do even test for the near vision. For that, we use the Snellen's near type test chart, which is there. These are all available in the market. It's very low cost. You can purchase them and then you can use them in OPDs. So this is a Snellen's vision test type. And here you can see in Kannada, there is written as N6, N9, sorry, N8, N10, N12, N18. These N18 and 12 is the size that you use in the Word files while typing your letter. You might have seen that in computers, when you type some letters, you can arrange, you can resize your words. So those word size are being described in the N. It does not describe any, signifies any distance. So N6 is the normal vision for a person at 33 centimeters from his eyes. That is most important. So whenever you are reading any objects, it should be ideally be read at 33 centimeters away from your eyes. And he should have an N6 vision. And the N36 means that he is not able to see the smallest, or he is able to see only the big ones. Okay. Now, for any vision defects, these are the commonly used instruments to identify the how much power or how much degree of loss the person has. The first one is an auto-refractometer. You can see this in the picture. The first one is an auto-refractometer. You might have all seen this in any optician's shop, or for the people who are using spectacles. You might have seen your ophthalmologist using this machine to check the power of your eyes. So ideally, whenever if your eye vision is very true or very normal, this will be around plus or minus 0.25. And if depending upon the degree of your visual acuity error, there will be more and more negative or positive numbers getting into this. Now, negative numbers and positive numbers is depending upon the condition that you are exhibiting. If you are having a myopia, you will be having negative numbers, and if you are having a hypermetropia, you will be having a positive numbers. Okay. So again, there are two kinds of lenses that which we use. One is a spherical lens, and second is a cylindrical lens. Okay. So spherical lens describes you have a normal 360-degree axis that is fully implied to the eye, and a cylinder lens gives a particular axial power to the eyes. This is very important. So in a person who is having a spherical negativity, you can say that only spherical negativity, you can say that the person is myopic. And if cylinder power has come there, you can say that the person is having astigmatism, where there is cylindrical power. Okay. Now, the second instrument that we use is the lensometer. Again, this you might have seen in shops, where you bring a spectacles, you keep the spectacles inside this area, and you can see that the spectacle power that the person uses. And the lastly is the phoropter, which we don't see everywhere in clinical practice, because this auto-refractometer usually gives the power of the eyes, and so we don't use the phoropters. Instead, we do manual refraction for the person using a retinoscope and to get the powers. Okay, so phoropter is a machine device that is used to get the power of the eyes. What kind of glasses, what power of the glasses should be prescribed to the person who is having a visual defect. Now, all these is an advanced area of ophthalmology. I'm not going into the details of this. I'm just only making you understand that there are such instruments which can be used for calculating the eye powers. Okay. Now, the next most important area that after the visual acuity is the visual field examination. Everyone might know the visual field, that is whenever you are seeing a point object with any one of your eye, you can even perceive its surrounding areas. even if you are focusing on one object, you can see even the surrounding area. This surrounding areas, what you see is the visual field. That is, if you are watching a television, if someone comes from the side, he approaches you, you can see that he's approaching you. So this vision field is the visual field that you can see. So if you start from the nasal area till the temporal area, I can say that if I start from the nasal area, I can see that roughly there will be for 50-degree field on the nasal area. You can have a 60-degree field on the superior area, a 70-degree field on the inferior area, and a 90-degree field, 80-degree field on the temporal area. That means you can see the rightmost end of your any object that is coming from the rightmost end, but as it goes to the left side, you can see that it gets faded out after a certain area. So the field in the nasal area is less, and the field in the temporal area is more. So nasal area is that which is close to the nose, and the temporal area is the area which is closer to the temporal bone. Okay. So, and how you check this I hope you might have done, you have taken this in the graduation. That is, you ask the person to close one eye, and the same opposite eye, the person, the physician closes. You ask the person to see your eyes itself, and you divide this into quadrants and bring any moving objects or any bright objects from side towards the inward side. That is, see from the side, see how my cursor moves. Just a minute. From the side towards inward, from the side towards inward, from the side towards inward, from the side towards inward. So this is how you check the visual acuity. You can see, you can get a lot of YouTube videos on how you can do the clinical visual field examination. And this is very important, especially in people who are having retinitis pigmentosa, which is the hereditary disorder. It's a genetical disorder. And in glaucoma, where you can have a gross idea of visual field examination. So it should be given knowledges on visual field examination. Now there is an objective method to collect the visual field, which we call as Humphrey's visual field analyzer, and the test is called as perimetry. So you might have all you might all know what is perimeter. So the surrounding area, the total area. Okay, so perimetry. This report you can see in every person, almost every person today who is going an ophthalmologist for his glaucoma evaluation or his visual field evaluation, and you can see these areas. See, you can see the white areas indicate the areas of vision. The black areas indicate the areas of less vision. You can see in this picture, there is a blackness more in this area. Okay, see, blackness more in this area. So that indicates that there is a visual loss. And you can see one black dot here. Okay, this black dot is not an area that is of vision loss. It is that of optic disc. Optic disc actually does not have any photoreceptors, so that does not give any vision. So that is why it is called as blind spot. Okay. Now, when in any visual field examination or any perimetry report, even though I have shown you the initial areas, what you have to take into consideration is this part which I am showing, that is the mean, the pattern deviation area, which is mean, because these pattern deviations gives us the data by removing all sorts of errors from this calculation. Because this is a computer generated calculation, there can be errors. So all those errors are removed and then projected as pattern deviations in this. So you can see that in this pattern deviation, there is a major area, that is the inferior quadrant has almost everything has been come into black. And you can see even the superior quadrant is also coming into such manner. If you see in this picture, you can see the inferior area, one or two areas has been spared. Only one area in the superior quadrant has been given black. And in this first picture, you can see that one or two points in the inferior quadrant on the nasal area, you can see that there is black spots which indicate that there is a loss of vision. So whenever you get a perimetry, you go for this pattern deviation, understanding the pattern deviation to understand what is the visual field loss of the person. All the black areas indicate there is a loss of vision. Okay, see there is in this picture you can see the pattern deviation. You can see the black areas is more on the superior area. Okay, superior part. And you can see for a general idea this is enough, because each and every area indices there is much to learn about perimetry, but on a gross concept this would be fine. And another most important point what you should know is that the false positive and the false negative errors that is raised in this these two things. False negative error should be always less than 20%. That should be noted. If it is more than 20%, the report that you have brought is wrong. That should be very important. And you can see even GST, that is glaucoma hemi field test. If it is within normal limits, that is there is no glaucoma for the person, and if it is outside normal limits, that is there is glaucoma for the person. And how much glaucoma, if you want to see, you can see the MD, that is the mean deviation. So the mean deviation should be always less than -2, and anything which is more than -2, that is -3, -4, -5, those all things shows that it is a highly glaucomatous area. So you can see that the entire area in this the superior, we call it a superior arcuate pattern. So the entire superior area has been turned into black. That is this area, the field of vision has been lost, and hence you can see that there is -12 that has been shown in the perimeter. Okay. Now we are after the visual examination and visual field has been done. Now we start examining each and every part of the eye that is accessible from outside. So ideally, you require a slit lamp, which is usually seen in an ophthalmic OPDs, and you do it even with a binocular loop. So binocular loop is nothing but it's a magnifying glass which gives you around 10 times magnification. I do feel that even you can use even with binocular loop. This is usually available everywhere in market. You can search online, you get this, and it's not too costly. You can buy that, but slit lamp is costly. At least you need to spend at least say 1 lakh rupees for a minimal slit lamp. So that's a very costly investment. You can go for a magnifying binocular loop for examining the normal parts of the eye. Okay. Now, examination of eyeball as a whole. So these are the 4 points that you should keep in your mind when you are examining the eyeball. So they are the position, size, axis, and movements. Okay. So just let me first bring your attention to the picture which is there on the below. Okay. You can see that both the eyes are equally placed well inside the orbit. Okay. But you see the above picture. Okay, this picture and this picture. You can see that the eye is being protruded outside from the orbit. Okay. So this kind of protrusion, which is occurring due to a non-metabolic cause, that is a non-thyroid cause, is called as proptosis. And if it is occurring due to a thyroid abnormality, it is called as exophthalmos. So please remember this. So now how can you identify whether the eyeball is inside its socket or not? If it is clinically evident, as in this picture, you don't require anything. But if it is not clinically evident, you can use a scale, and the eyeball should fit inside the scale. If the scale is kept on this superior orbital margin and the inferior orbital margin, if you keep a scale, if you join a scale, the eyeball should be inside that. So in such areas, the position of the eyeball is normal. So this you call a proptosed eye. If it's a non-goitric, that is a non-thyroid cause, and if there is a thyroid abnormality, and due to a thyroid abnormality, if it is being bulged out, it is called as exophthalmos. Okay. Now, position of the eyeball, you have, now we have seen outward protrusion. Now see, we are seeing with the inward protrusion. You see this picture, okay. You can see that the eye on the left side, the eye on the side is normal, while the eye on the right side is between has gone inside. Okay, so there are three conditions which we call as microphthalmos, enophthalmos, and phthisis bulbi. So these three conditions can present as on the picture 1. So microphthalmos is a condition where the eyeball itself is genetically small. Enophthalmos is a condition where the eyeball has gone inside due to some external factors. And phthisis bulbi is a condition where the eyeball size has got shrunken due to any degenerative conditions. So in all these three cases, the position of the eye gets inside of the orbit. This is what we call as either microphthalmos, enophthalmos, or phthisis bulbi, depending on the condition. And you can see in this picture, the below picture, you can see in the left side, there is a normal eye. On the right side, you cannot see any eye. See, there is no eye. We call it as enophthalmos. That is, there is no eye. Okay, enophthalmos. Now, you see this picture very clearly. Okay, see, this is a right eye for the person. You can see the cornea, you can see the sclera, everything very clear. But in the left eye, watch out, this cornea and the sclera, it's an artificial. So this is a prosthetic eye. So in enophthalmos patients, in order to avoid, in order to bring cosmetic betterment, a prosthetic eye is maybe kept so that which you may feel that the SI in this, actually blood vessels are not drawn, but you can even see in prosthetic eye blood vessels are also drawn in it, so that at a side you will not feel that the person does not have an eye. So you have to even watch out for the prosthetic eyes. Okay. Now, to determine the size, especially if you want to understand whether it is a macrophthalmos or whether you want to understand whether it is a macrophthalmos or it is an enophthalmos or an exophthalmos or it's a proptosis, you can order for an A scan. So A scan is actually a biometry, that's an ultrasound scan where the ultrasound probe will be kept over the eyes, and then the rays will go inside, and you can see even the length of the eye that is being depicted as in the below picture. See, you can see the length of the eye. Okay, so here in A scan, normally the length of the eye is being described as 24 mm, but it's usually they don't adhere to the 24 mm as correctly. It may go, it actually varies from 21 even to 28 mm, it varies. Okay, so you can see that the description that has been shown in this is 27 for the left eye and 27.71 for the right eye. Okay, so what the point which I would like to show is that any person who comes to you, if you want to see whether the eyeball has elongated or not, or whether it is a genetically small or a big eyeball, or is it due to some other, or is the eyeball eyes normal, you can go for an A scan. But usually A scan is being done for cataract surgeries because they need to know the length of the eyeball so that they can keep the correct power of the intraocular lens. Okay, but in Ayurveda also, we have seen few studies that has been using A scan, especially in myopia. What happens is that the length of the eyeball increases. Okay, so A scan studies are being done to know whether there is any change that has been brought by the Ayurvedic treatments to the length of the eyeball. A scan has been utilized. So A scan helps in identifying, determining the size of the eyeball. Okay. Now coming to the visual axis. Next part that you need to examine as eyeball visual axis. You can see in the first picture that is the both eyes are normally directed to a single object. Both eyes move together and both eyes are directed to one object. But in the next picture that you can see, the second picture, you can see that one of the eye, that is the right eye, in this case, is directed towards the nose. Okay, we call such kind of changes in normal terms as squint, and in medical terms as esotropia. So eso means something that is directed towards the left, and exo means something that is directed outwards. And I cannot say the left. If it is directed inwards, it is eso, and if it is directed outwards, that is exo. So you can see directed which is outside and which is directed inwards. Okay. So any next important thing that you should note is what is the nature of the visual axis. Is there any kind of esotropia or exotropia? Okay. Now, when such a kind of esotropia or exotropia appears in your OPD, and you want to know whether your treatment, because many people will be coming to our OPD for getting a treatment for such condition. You want to know what is the status, how far you have treated them, whether any beneficiary, when anything has been improved. This is a gross methodology that you can follow, which we call it as corneal light reflex test or a Hirschberg test. Okay, you can see the first picture. In the first picture, a simple torch is being shown in front of the person at a distance of nearly half a meter, and you can see that the torch light is being projected on the right eye, on the left eye, almost in the center of the eye. Okay, almost in the center of the eye. You can see this picture. You can see almost in the center of the eye. Sorry, this is the picture. Almost in the center of the eye, you can see the picture. Okay, see almost in the center of the eye. But in the second picture, you can see that for the left eye, the light is being projected near to the pupil, near to the pupillary margin. So you can see near to the pupillary margin, and you give a 15-degree deviation to the eye. 15-degree deviation to the eye. In this third picture, you can see that the pupillary margin is being crossed. See, you can see here, the pupillary margin is crossed, and it is appearing on the iris. The light is appearing on the iris. So you describe it as 30-degree deviation. And you can see the last picture. In this picture, you can see the last picture, even it has reached the corneal and the scleral junction, the sclerocorneal junction, which we call as the limbus. Okay, so and for that, you can see the eyes which we give 45 degree. So based upon the degree of deviation on the Hirschberg test, you can note down what degree of the deviation you had initially before the treatment and what degree of deviation is existing after the treatment. And you can show to the patient, or you can describe it. Okay, anyway. Okay, this is what is called as Hirschberg test. Now, any person who is coming to you with any esotropia or exotropia, you should do some cover and uncover test. This is very important. Why is this? Because any person who is coming to you, there can be chances that there is any latent kind of squint. That is, latent kind of squint means that when you cover any of the dominant eye or any of the eye, there are chances that there are hidden squint which is in the eye shall manifest. Okay, I'll show you in the picture which is shown below. See, in the first picture, you can see that both eyes, the visual axis is normal. Okay, we call it as orthotropic. I cover with a paper with the left eye. So only right eye now takes into charge to see the objects. So what happens is that left eye, there is already a squint which was hidden, and you can see that the left eye squints up. So hidden squints can be seen using cover uncover test. And this should be very important, because you will miss this kind of squints in your normal OPD. We will be considering the persons as orthotropic by seeing the normal eyes. So you should be always checking for the presence of any hidden squints. Now, this is a very advanced one. I just put this in slide for people who are practicing Shalakya. They can use this based upon the cover and uncover tests. You can see in which kind of eye there is dominancy and in which kind of eye there is non-dominancy. I'm not going to describe this in detail. You can just read up this. That's self-explanatory. Okay. I just go with the movements of eyeballs. Okay. So the movements of eyeballs, we have seen, we have the most important mnemonic that you can remember in this is SO4, LR6, REST 3. That is, the eyeball is supplied by 3 cranial nerves, in which SO4, that is superior oblique, is supplied by the 4. LR6, lateral rectus, is supplied by the 6th nerve, and REST 3, that is all other nerves are being supplied by the 3rd cranial nerve. Okay, so what you do in every person who comes to your OPD is that you check the range of movements of your eye. Okay, and you can see how the range of movements is being tested. That is, you tested on the up left, up center, and up down, and you can see on the upright, up right center, and right down. So this is how you test for the visual movements of the eyeball. You note whether the person is able to move it in the full extent or not. Sometimes in squint people, you need to check. In squint people, you need to check the extent to which they are able to move this, because squint can be caused even by one cause, which is called as the neuroparalytic causes, where due to any nerve involvement, the squint will be manifesting. In such conditions, you should be able to understand which squint has been paralyzed, or which nerve has been paralyzed, and which can be examined by using the above picture, which has been depicted here. That is, if the person is not able to move his eyes towards the lateral rectus, that is lateral side, it means that his 6th nerve has been paralyzed. If a person is not able to move his eyes towards the medial side, it means that his 3rd nerve is paralyzed. So in this manner, you can use this picture for identifying which nerve has been paralyzed. Okay. Now, we have completed the eyeball on a gross. Now we are going to the palpebral aperture. So palpebral aperture is nothing but the space which is being shown from the side, which I have drawn the space. Okay, this space is called as the palpebral aperture. Palpebra is the eyelids, and the space that the eyelids create for the eyeball to expose to the world, external world, is called as palpebral aperture. Okay, so the palpebral fissure height. So it's actually, aperture is actually space. It's a hole. Okay, so if you remove the eyeball, you can see that, and if you put a finger, you can see that's a hole. Okay, so it's a space, it's a fissure, and the vertical height, that the maximum vertical height that is being shown, that is used to come for a person, is 10 to 12 millimeter. Just a minute. Hello? Yeah. So, and the length of the palpebral fissure is 25 to 30 millimeter. Okay. Now, we should understand a few things. That is, if the vertically wide, which I told, the 10 to 12 millimeter wide palpebral fissure, sometimes it can come as narrow. That is, you can see that eye has been closed. In the earlier picture, you can see, which we have shown here, in the first picture, you can see that here the palpebral fissure has been, the size of the palpebral fissure is less, right? You can see the palpebral fissure is less. Okay, and even you can, in this eye source, you can see the size of the palpebral fissure, that is the height of the palpebral fissure is less. Okay, so palpebral fissure will of the eyes will get less in conditions which is affecting the eyeballs, in conditions where there is any nervous problem to the eye. Okay, we will discuss in detail. Okay, so the position in eyelids, you should go for the position, movements, margins, swellings, and the skin surface. Okay, See, you can see the normal position of the eyelid. You can see the palpebral tissue. You can see that the upper eyelid covers the 1/6 part of the cornea. You cannot see the upper area of the cornea, right? But you can see in this below picture, you can see the upper area of the cornea. But in the lower lid, it just touches the cornea. This is very important. So this is the normal position of the eye. You see in this left picture, which is there here, you can see that it has crossed, it has covered more than 1/6 part of the eye, and the palpebral fissure size has been less. So this is condition called which is drooped lid, and it usually occurs in ptosis. It does not mean that it occurs only in ptosis. In the earlier picture, we have seen in anophthalmos, we have seen in microphthalmos also the palpebral aperture size will be less, but there the lid is not drooped, but it means the lid is drooped, but it is occurring due to some other cause which is inside the eyeball. So you need to understand the cause why the drooped eyelid has been occurred. Right now, I'm only discussing on the examination, what all you should do here. Okay, not on the diagnosis part. So you should examine the size of the palpebral aperture, where you can see in the right eye there is drooping of the eyelid, while on the left eye you can see that the eyelid is normal. And you can see in this eye, that is in the below picture, there is we call it as lid retraction, where you can see the upper part of that is upper scleral part of both eyes. We call it as lid retraction, and usually you see this in cases either of exophthalmos, or you can see even myasthenia gravis also you can see this condition. Okay, lid retraction. So what you have to, when you are examining a patient, you should note whether the position of the eyelid is normal, whether it is drooped, or whether it is retracted. Now, for the lid movements. Now, the basic function of the lid is movement. That is, you close and open your eyes, and they protect your eyes from any kind of external faculties that is coming to the eyes. Okay, so now you check for the increased or decreased blinking of the eye. And the normal blink rate is around 14 per minute. There can be increased blinking. So you note down that. And then you see the lid lag. Lid lag is you ask the person to close your eyes, and immediately the upper eyelid should follow the eyeball and get closed. That is how it should be done. Okay, but in person, especially in old age, you can see that the moment you ask the person to close your eyes, the lids will be coming very slowly, and only they will be closing. That is called as lid lag. And in some person, as in this picture, you can see that the eyes will not get completely closed. That is called as lag of ophthalmos. That is, when you ask the person to close the eyes, you can see that in the diseased eye, the person will not be able to close this eye, which is called as lag of ophthalmos. So in this should be taken into consideration while you are examining the eye. You should ask the person to close the eye. Okay, in Ayurveda, you can compare this as both these lid movements with Vada Hatha Vartma, one which has been described by Susruta, and other which has been described by Vagbhata. Okay, now coming to the lid margins. So there are two lid margins for every eyelid. This is the upper eyelid margin. This is the posterior lid margin of the upper eyelid. This is the posterior lid margin of the lower eyelid. This is the posterior lid margin of the lower eyelid. Okay. Similarly, you have the anterior lid margin of the upper eyelid. This is the anterior lid margin of the upper eyelid, and anterior lid margin of the lower eyelid. And in normally, the posterior lid margin will be approximating to the sclera, to the eyeball. This is very important. Okay. Now, what you see in this first picture, you can see in the first picture that in the anterior lid margin, there will be anterior lid margin, there will be the eyelashes. Okay. Now we can see in the first picture that the anterior lid margin has been turned inward to make the eyelids eyelids adhere to the sclera, okay, or touch the sclera. Such a condition where the entire anterior lid margin has been turned inwards is called as entropion. Okay. Now you see the reverse of this. The eyelid margin has been turned extra outwards to make, you can see this in this picture, this is called as ectropion. So what is the problem that will happen in an entropion person? Because there is eyelashes, these eyelashes will be rubbing over the cornea, over the conjunctiva, and there will be constant watering of for the person, or there can be aberrations which can lead into photophobia and corneal ulcers and all causes of complications in later areas. So you should be very careful whenever a person complains of watering of eye. You should check whether there is an entropion for the person. Secondly, for the ectropion, even ectropion person will also complain watering of the eye. Why? Because these, when the outward margin, when the outward turning of the lashes is there, the water that is being, the tear film that is being produced from the lacrimal gland, they get moved out from this eye. So what happens is that the person will still complain of watering. And since the tear is not standing here, what will happen is that this such an eye gets dried easily. So an ectropion person will always complain of dry eyes, and an entropion person will always complain of foreign bodies in his eye. Okay. Now you can see another condition where the eyelid anterior margin is normal. You can see that these lashes, you can see anterior eyelid margin is normal, but you can see some lashes which is touching the cornea and touching the conjunctiva. This is called as trichiasis. So the inward direction or the misdirection of the eyelashes is called as trichiasis, and they produce the same effect as that of the entropion. Okay. Now you can see that in some persons you can see there is absence of eyelashes. You can see there are no eyelashes here. Okay, that is called as madarosis. So whenever you see an eye, you check whether there is an entropion, trichiasis, or a madarosis for the person. Okay. Trichiasis can be compared to as Pakshmakopa in our in Ayurvedic literatures. Okay. Now you can see in this picture, in some parts of the eyelashes has been graying of eyelashes has been there. This is called as poliosis. Okay, and you can see that in some persons this requires actually an experience to understand. There can be thickening of the eyelid margin. See, you can see the eyelid margin has been thickened. So that's thickening of the eyelid margin is called as tylosis. And in this picture, you can see that apart from this anterior eyelashes in the anterior lid margin, you can see there are some eyelashes even on the intermarginal strip. Okay, this is called as distichiasis. Distichiasis means there will be one more row of eyelashes. We call it as Upapakshmamala in Ayurveda. And you can see in some persons there is blepharitis. Blepharitis is nothing but these scales that is coming in the eye. This is a very common presentation which you can see. You can see scales on the eyelashes. This is seen in blepharitis. So whenever you are examining any eyes, check for any of the signs which I have shown here, whether it is there for the person or not. Okay. Now you can even find some eyelid swellings. Okay, you can see in this. See, this is called a stye. Stye is nothing but the inflammation of glands of C's or moles. Okay, and you can see there is you can see chalazion here, which is the inflammation of the meibomian glands. An acute inflammation of meibomian glands will be represented by an internal hordeolum, or you can see a generalized swelling of eyelid, like lid swelling. This is very common. You can see in every day-to-day clinical practice. You can check for any of the presence of any of this local swelling or a generalized swelling. You can even see for molluscum contagiosum. You can see the molluscum contagiosum. You can see this molluscum contagiosum, which is actually molluscal infection, helminthial inflammation, infection of the eyelid. And you can see some people like this. Don't get confused with the molluscum. It's actually nothing but the blackheads that is appearing in the eye. Okay, the blackheads may appear in such a manner, so watch out for this. Or you can see even warts. This is also very common presentations that is there in the eyelids. Okay. Now, after the eyelids have been examined, now we are going for the lacrimal apparatus. Okay. Again, you might have seen the anatomy of lacrimal apparatus. It starts from the lacrimal gland on the lacrimal fossa, and then it has the lacrimal sac is there. Lacrimal. You have the palpebral aperture. Then you have the lacrimal puncta. Here is you have the lacrimal puncta. You have the canaliculi, and then you have the lacrimal sac, and then you have the nasolacrimal duct. Hello. Hello. Am I audible? Hello.
Yeah. Sometimes the voice is breaking.
Okay, that may be due to the net issue.
Hello? Yeah, sometimes the voice is breaking, doctor.
Okay, am I audible right now?
Hello, doctor? Yeah.
Am I audible right now?
Yeah.
Audible. You're audible, sir. You're audible. Yes, sir. You can continue.
Yeah, okay. Yeah, okay. So now we need to examine the lacrimal sac, lacrimal punctum, and do a regurgitation test, which is very important. See, this is a very common clinical presentation. Dactylocystitis you get in OPDs. You can see the lacrimal sac being inflamed. You can see there's a lacrimal area sac that is getting inflamed. Okay. We call it as Puyalasa in our science. And any person who is complaining of watering or pus discharge in the eyes, the Srava Roga, okay, you have one test which is called as a regurgitation test, wherein you use your index finger and then press on to this area, that is press on to the nasal area where you have a lacrimal sac here, a lacrimal duct here, you press here, then you can see that the pus will be coming from the puncta. So this indicates that there is a block in the nasal this area, that is the nasal canaliculi or in the nasal sac. There is a block which is being regurgitating the pus from the outside. So any person who is complaining of the pus, you can just check for the the regurgitation test. Okay, this is very important for a dactylocystis condition. Now, after the lacrimal area, then you have the conjunctiva for the examination. So you have a conjunctiva, you have three areas. One is the bulbar conjunctiva. Then you have a palpebral conjunctiva, which is either lower or upper palpebral conjunctiva. And then you have a fornix. Okay. So lower palpebral conjunctiva is examined as in this picture, where you ask the person to see up and you pull the conjunctiva down and you see the lower conjunctiva. For the upper conjunctiva, I prefer to use a cotton bud because that's very easy. You take a cotton bud, you keep as a fulcrum on the upper eyelid and then invert the eyelid so that you can see the upper conjunctiva and ask the person to look down. That is very important. Ask the person to look down. Okay. Now, for a conjunctiva, you examine its discoloration, you examine its congestion, edema, growth, scars, and foreign bodies. Okay. So these are some of the conditions which you commonly use, which we commonly meet. One is the melanosis, which is very common. You can see people who are especially working in dirty areas, you can see brownish discoloration that is happening onto the conjunctiva. Arthrosis is not that common. It is due to silver nitrate affecting area. So that have to usually come in people who are working in silver companies. That's not so common. Then you can see the subconjunctival hemorrhage. We call it as Arjunam in Ayurveda, where you can see reddish parts. In this condition, the most important thing which you should note is that, see this in this subconjunctival hemorrhage, you can see I can make out the border of this subconjunctival hemorrhage, right? Okay, this is the border, this is the outline of the subconjunctival hemorrhage. Even you can see in this, the other side also. So if you can make out a border of the subconjunctival hemorrhage, it is called as a safe subconjunctival hemorrhage. And if you cannot make out the border of the subconjunctival hemorrhage, it is not safe, and then it is better to refer the person to higher center to see from where the bleeding is coming. So you should be able to identify the safe subconjunctival hemorrhage and unsafe subconjunctival hemorrhage. Okay. Now, there is a pale conjunctiva. This is very common. You need to identify the paleness of the conjunctiva. Okay. Now, this is follicles. This is very commonly seen, follicles. So, follicles, there are three types of presentation. One, you can see dots like this, okay, which is there inside the eyes. This is especially seen in people who are complaining of itching of the eyes. You can see the follicles, or you can see follicles in this kind of follicles with erythema, which is usually seen in viral conjunctivitis. Or you can see a bit elevations, small elevations like boiled sago grain elevations. You can see here. These are also follicles, which is seen in trachoma or acute follicular conjunctivitis. You can see in this. So these follicles also should be able to identify. Now we can see papillae, which is here. We can see the difference between papillae and follicles. Follicles are actually like grains, while papillae are, you can see, it's a flat topped elevated areas. You can see the flat topped elevated areas. Okay, so you should see whether there is papillae or not. Usually such kind of papillae are seen in extreme allergic reactions in giant papillary conjunctivitis. Okay, or you can see the presence of cyst. You can see there is a very big cystic swelling that is happening in conjunctival cysts, inclusion conjunctival cysts. And this is also very common, you can see whether there is a presence of any chemosis, that is edema of the conjunctiva. You can see that the conjunctiva has been got edema, especially you can see the fluid collection here. Okay, this usually comes especially in allergic reaction. Something goes to your eye, some trauma happens to eye. This kinds of reaction, you have to check for such kind of findings. Okay. Now you have a pingicula. Pingicula is a yellowish raised area that you can see in the nasal area. Pingicula. Again, this is more commonly seen in people who are working in dirty areas, in dusty areas. Then you have to check for the presence of foreign body. You can see a foreign body in this eye. A person who has complained of something that is touching, something that is gritting sensation in his eye. You should always check for the presence of a foreign body, and you should check even for the presence of concretions. You can see hard, yellowish white nodule-like structures. This is called as concretions, which are actually desiccated mucus, and they are formed into hard structures, which actually impinges the touches the cornea and making it as a foreign body sensation. And in some people, you can even see scars. You can see conjunctival scars. But now this is not very so common in India, because this was usually seen in trachoma, which is a non-communicable disease. It's a communicable disease, but trachoma has been brought under control right now. But initially there was trachoma was used to occur in a very large number, and which has a sequelae as conjunctival scarring as a sequelae, and we used to see this. But right now this is very less. Okay, but still you have to check out whether there is any presence of scars. Now you check for any growths. So you can see this as the same color as that of the sclera. They call it as dermoid, and the specialty of dermoid is that you can see the hair growth that is there in it. Okay, hair follicles can be there. Okay, and check out for there is a very common presentation that is called as pterygium, the armum that is being told in our science. The most important feature with armum is that the pterygium is that as the pterygium approaches the cornea, the shape of the cornea will change, and which will lead to the bringing in cylindrical powers to the eye that will lead to the visual disturbances. So that is the most important point that you have to keep in mind when you are coming, when a person comes with pterygium to eye, that is, the person may have a chance of visual defect. Just a minute. Okay, and then you can see when such kind of presentations, which as shown in the picture, it can be then a carcinoma, or it can be a papilloma, that is to the eyes, you can see. But in our state, it's difficult to, because such people, they actually they are being diagnosed at the early stage itself, and they're being treated. But in rural areas, you can see such kind of people who don't show to the doctors, who don't go present themselves in front of the doctors. You can see kind of presentations, papilloma and carcinoma. Okay. Now, after the we have right now we have learned regarding the changes. Now we'll go with the examination of sclera. Okay. Now in sclera, you should see for the discoloration, inflammation, and lump that is happening. So this is very classical. You can see the yellowishness of sclera. Normally the sclera is white, but you can see yellowishness of sclera, which is which we all know that it is seen in the jaundice condition. And you can see, or you can see in bluishness of the sclera. This is very classically seen in the condition of osteogenesis imperfecta. And then this is also a very common condition. You can see a blackish brown, chocolatey colored small local lesion of nevus of aorta. We call it as nevus of aorta. I've already mentioned melanosis in previous condition. These both are melanosis. One is a circumcorneal type of melanosis, and other is a sectoral type of melanosis. Okay. Now we'll go to you can see a presence of an illum. You can see something that is being protruded from here. This is called as the staphyloma. Actually, this is the choroidal tissue that is coming out from the thin sclera. Okay, this is called as staphyloma. Okay, and there is staphyloma which has been coming to the cornea. We call it as ajaka in Ajaka Jata in our science. Okay. And you can see, especially in people who are having glaucomatous surgery, you have undergone the glaucomatous surgery, you may be able to see such kind of elevations here. Okay, this is called as a scleral bleb. What they do is that they elevate this flap of conjunctiva and they make the excess aqueous humor to drain into this bleb so that the pressure of the anterior chamber is being decreased. Okay, so there may be presence of a scleral bleb. Okay, and then you may have even check for the presence of nodular scleritis. You can see some nodules and you can see some inflammation over it, which is called as nodular scleritis. Now we are examining the cornea. We have the size, shape, surface, sheen, sensation, and transparency. Okay, so the normal cornea, it's a transparent watch glass structure where the average horizontal diameter is larger, that is 11.7 millimeter, and vertical diameter is 11 millimeter. Okay, we can see the size of this. You may see in congenitally, you may see the size of this as less. It is a microcornea. You can see the size of this as less. Okay, this part is sclera, this part is cornea. Okay, this is microcornea, and then, or you can see even macrocornea. You can see how the big the cornea is. You can see even macro compared to this size. Okay, this is a macrocornea. This is actually a case of a Bouff's thalamus. Bouff's thalamus is the increased pressure in the eye that which is bulging the eye, which is producing the macrocornea. Okay, Bouff's thalamus. Now you can see the shape of the cornea. Normally, the corneal shape is actually it's an elliptical shape that you can see in this. It's a watch glass structure. Okay, but sometimes what it may get as a globus shape. You can see this is a globus shape. Okay, so it is called as keratoglobus. So all the words which is using kerato means the cornea. Okay, and sometimes you can see that there's a cone shape, which is we call it as keratoconus. Okay, this is keratoconus. Okay. Now, to determine the corneal surface, that is a shape, that is corneal curvature, we use keratometry, which is an instrument which is being denoted by K1 and K2 values. So this denotes the K1 and K2 values. I'm not going into detail of all these instruments, just to understand that it's you can use as keratometry, and keratometric values are again they are usually available on autorefractometers with keratometers. So you have instruments in such a manner that both keratometer and autorefractometer will be there, and these are again keratometric readings are again used for calculating the power of the intraocular lens that is being used for cataract surgeries. Okay, just remember that the keratometry is there, which helps in determining the curvature of the cornea. Now, this is very important, corneal surface. To know that, because the cornea is an area, if you see the cornea, you can see like it is an hill. From the top of a hill, it comes down in a very systematic fashion. But to know whether is there any change in the systematic fashion of the surface of cornea, you use something called as Placidus disc. This is the Placidus disc. Okay. This is the placidose disc. This is very commonly available in the market. You can use this as placidose disc. And what you do is that there is a peeping hole in this placidose disc, and then you project the placidose disc onto the cornea, and you can see that the Meyers of the placidose, that is the white Meyers of the placidose disc, will be projecting onto the corneal surface. And now we earlier in the earlier slide I have shown you that the horizontal length of the cornea is more. So you can see the horizontal length of the cornea is more and the vertical length of the cornea is less. Okay. So in normal cornea, there should be these should be equi-spaced. These Meyers should be equi-spaced. Okay. Now you see this in this picture. There is an inferior steeping. That is why the inferior areas has been these areas they have been left, and these areas has come together. So this is an inferior steeping of the corneal surface, and you can see there is an irregularity. See, you can see some Meyers attached together and some Meyers attached together here. Some Meyers are distant. Okay. So if you see such type of images, you can see that the cornea is irregular. Okay, and this is very important. So you can see an irregular cornea here. So you can see an irregular cornea here and irregular cornea here. Okay, so this is very important when you are checking the corneal surface. Okay, so to understand the corneal surface, we have an investigation which is called as corneal topography. It is again a very big subject. Showing, and right now the only thing which I would like you to get introduced is that the images which are shown in warm colors will have a steep cornea, and a cool colors which will have a flat cornea. That is, cooler the colors, the cornea is better, and warmer the colors, there will be severe surface. This is Hello? Hello? Hello?
Hello. Yes, sir. It is audible. And all the attendees, please unmute your audio.
Okay. So,
Dr. Rao, kindly unmute your audio.
Okay, so I'll continue with this. So even in the, see, you can see this is the curvature area, which is very well written here in the front. This is the sagittal curvature that is being shown. So better you go only with the axial, that is the front area, the sagittal curvature. And if you see redness, that is if you see red areas, it means that there is steepness. And if you see there is a cool areas, that means there is flatness. So this is very important when you are checking with the corneal topography. Okay. Now, see, I'll show you. See, in these areas, see, you can see in this marginal corneal degeneration, you can see there is warmer colors in this area. Okay, that means there is a warm corneal degeneration that is happening in this picture. Okay. Now, let me take another picture. This is a keratoconus. You can see there is warmer colors here. You can see the presence of warmer colors in this. That means there is steepening more on this area. Okay. And you can see a regular astigmatism. This is very common presentation. Whenever there is an astigmatism which is regular, you can see that a bow type pattern. See, you can see a bow type pattern. You can see a bow type pattern which is coming here. Okay, this is called as a regular astigmatism. Okay, and you can see an irregular matism. See here, you can see the bow type pattern has been lost. Here the bow tie pattern is not as clear as this one. Okay, so this is a regular astigmatism and this is an irregular astigmatism. This should be very important. This should be, you should note this. Okay. And there is with the rule and against the rule of astigmatism. I'm not going deep into it. Just remember these 2 points, that is irregular and regular astigmatism. Now there is something important which is called as corneal sheen. Okay. Now, see, this is a normal cornea. You can see that the Meyers which we see with the placidose disc, they will be very you can see the borders are very sharp. Okay, and if the sheen is lost, you can see the Meyers are being irregular. See, you can see the Meyers are actually irregular in this. This is called as corneal sheen. Corneal sheen is actually lost in dry eyes. So if you want to know whether there is a dryness of the eye, you can use a placidose disc and check for the corneal sheen. Okay. Now, this is usually being done by ophthalmologists or people who are practicing Shalakya, where fluorescein staining is also done or rose Bengal staining is done. So here you put an anesthetic drop into the eyes and then you put a fluorescein stain and you require actually cobalt blue light. See, this is what you see in this eye, projected into eye is cobalt blue. And when you put a cobalt blue, you can see the fluorescein staining that is coming. So you can see if there is any epithelial defects that you can see in this epithelial defect. This is actually a dry eye. You can see the tear film being broken at various areas, and this is an epithelial defect at this area that is coming here. And even you can see dendritic herpes, dendrites of the herpes in herpetic ophthalmicus. You can see very clearly using fluorescein. So fluorescein stain is actually used to see whether there is any epithelial defect that has been occurred in the cornea. And UVU is even rose Bengal stain, but rose Bengal stain is not that commonly used because rose Bengal is actually creating very irritation to the eyes, and hence this is used only when we were very sure whether to see the presence of any devitalized tissue in the eye. Okay. Now you need to check the back of the cornea where you can see such kind of muddy dots that is there, which we call it as precipitates and keratic precipitates. And keratic precipitates are usually seen in the inflammation of the that is in uveitis. That I would like to say that is in iridocyclitis, uveitis. That is the more keratic precipitates will be there. So you should check whether keratic precipitates is there or not. Okay. Now, these days you can have surgeries, more of surgery, and you can see whether there is surgery or not from these appearance. See, this is a keratoplasty, that is corneal transplantation has been done, and the transplant, you can see the scar and the sutures of this scar of keratoplasty, and this is a keratoprosthesis, that is an artificial cornea has been kept. This is a keratoprosthesis. Okay. Now, corneal neovascularization. Normally, cornea is an avascular structure. You have learned in the last class. So you can see the presence of corneal neovascularization, which we call as a Sira Shuklam. There you can see that these conditions suggest that there was an inflammation in the cornea earlier that has led to the neovascularization of the cornea. Okay. Now check for the presence of any the transparency of the cornea. How the transparency is by seeing the presence of opacity. You can see some nebular opacities like some mild opacities here, or it can be a macular corneal opacity as some more dense, more cloudy appearance, or it can be a leucoma. It can be a leucomatous corneal opacity by seeing a very thick area of opacity. So this is very important. Okay, now this is very important. Now let us go with the next one, which is the corneal sensation. So what you do here is that you take a wisp of cotton, bring it from the lateral side and touch it over the cornea. So you bring it from the lateral side and then just touch on the beneath of the cornea, just on the cornea, so that you see the response of the person. Usually there will be a blinking reflex that will be done that indicates that the trigeminal nerve of the person is normal. Sorry. Okay. So that indicates the trigeminal nerve of the person is normal. And then any conditions which hamper the trigeminal nerve, you can see that there will be decreased corneal sensation. So in herpes zoster ophthalmicus, trigeminal nerve is affected, and hence in herpes zoster ophthalmicus, the corneal sensations will be lost. Okay. Now, the corneal endothelium. We know that the cornea has 5 layers starting from A, B, C, D, E, and the E. The endothelial layer is the innermost the layer of the cornea. And to know the number of the healthy status of cornea, we take the corneal endothelium scan, which is called the specular microscopy, wherein there are many things which is being done here. This is actually taken for the transplantation of cornea. You see whether the cornea is healthy for a transplantation or not. Specular microscopy is used, and then for this, the most important things which you should remember is the cell density, which I have written below. The cell density. So up to 40 years of age, the cell density should be greater than 2,500, and from 40 to 70 years of age, it should be more than 2000. Then the next point which you should see is the CV. That is, this is the CV. The coefficient of variance should be always less than 33. And then the hexa, that is, you can see the hexa or 6A. This should be always greater than 50%. Sorry. So hexa represents the hexagonal cells. So you have the corneal endothelium is actually made up of hexagonal cells, and the more the hexagonal cells, it means that the cornea is more healthy, and the lesser number of hexagonal cells, it means that the cornea is less healthy. So this should be noted in the mind. And if you want any kind of conditions like you want to see the status of cornea after a post-corneal transplantation, you can prescribe for a specular microscopic report wherein you can understand what is the status of the endothelium. Or after any cataract surgeries or any glaucomas, you want to see what is the status of the corneal endothelium, you can prescribe for the specular microscopy. Okay. Now next is the anterior chamber. You should be able to understand, examine the depth, contents and angle of the anterior chamber. See, these three pictures are self-explanatory. The pictures have been taken from the side of the eye. You can see how the depth of the anterior chamber is. Okay, see in this first picture, what is the depth? In the second picture, the depth is a bit decreased. And in the third picture, the depth is more decreased. See, you can see the depth is more decreased. Can you make it out? Right? See, the first picture, the depth is more. The second picture, the depth is decreased. And the third picture, the depth is more decreased. So every person, whoever comes to you, make sure that you examine the depth of the anterior chamber very thoroughly, because the most important fact in this is that when the depth of the anterior chamber decreases, the person, there will be blockage of the aqueous outflow, and which will lead to the glaucomatous condition. So you should be always examining the depth of the AC, very important. You can do it clinically by using an oblique flash light test. What you do is that you take a torchlight and flash it over, see the first picture, flash it over the lateral aspect, that is temporal area of the cornea in a perpendicular 180-degree fashion, so that the light passes through this area and comes out from this area, from the nasal area. Okay, so this is called as an oblique flashlight test. And what you see is that if the anterior chamber depth is normal, the light will pass from the temporal area and cross to the nasal area and go, and there will not be any shadow. But if the anterior chamber depth is less, what happens is that you will see a shadowing, because what happens is that this area will get elevated and the light will not pass through this area. So you will have a shadowing of this area. So you can see a shadowing of the area. So this is called as an eclipse sign. Can you make it as like an eclipse, right? So you can see an eclipse sign. So this will be seen in if the anterior chamber depth is less. Okay, oblique flashlight test. Now you can see the contents of the eye. Now, right now, during this area of surgery, you can see in cataract surgery, you can see the presence of intraocular lens. See, you can see an intraocular lens, which is called as an anterior intraocular lens. But this kind of lens is right now rarely practiced, because anterior intraocular lens are used to create glaucoma by blocking the anterior chamber. So right now, posterior chamber intraocular lens is being practiced. You can see blood collection in the anterior chamber, which is called as hyphema. They are actually usually in response to any trauma or infections, usually trauma. And you can see even hypopyon, see pus collection in the anterior chamber. This is actually after math of any infection. So check for the presence of hyphema or hypopyon. And then to evaluate the angle of anterior chamber, you do a gonioscopy, where you use a gonio lens on a slit lamp, and you can check, see, this is the iris, this is the cornea, and you can see the angle of anterior chamber. This is the angle of anterior chamber. Okay, you can check for the angle of anterior chamber, and objectively, you can now use anterior segment OCT. OCT is optical coherence tomography, which we'll be describing later. That they have been developing it. They have developed it for the anterior segment also, so that you can see, this is the iris, this is the lens, this is the cornea, and this is the angle of anterior chamber. So the lesser the angle of anterior chamber, there is the more chances of presence of glaucoma, more chances of getting a glaucoma, and the wider the anterior chamber, you can understand that the eye is normal. So you can objectively collect with the anterior segment OCTs regarding the documentation. Even in anterior segment OCTs, you can even see the status of the lens, how much cataract it has have, or you can even see the status of the cornea, what is the thickness of the cornea, whether it is normal or not. Is there any presence of opacities? What is the nature of the opacity? Has it healed? Has it gone? All those things can be seen even with the anterior segment OCTs. Okay. Now, different various inflammation, because we have crossed sclera, means, or we have crossed conjunctiva, we have crossed cornea, we have crossed sclera. There are some inflammations which is affecting these areas. Just a minute. Okay, so in the there are based upon the area of affliction. It can be a conjunctival inflammation or a circumciliary inflammation, episcleral inflammation or a scleral inflammation. So the basic point which I would like to point is that, see in this picture, you can see that there is inflammation only on the area just which is near to the cornea, which is called as circumciliary inflammation. And this type of inflammation is seen in uveitis. Okay. This is, you can see diffuse inflammation here. It is in conjunctivitis, and you can see large blood vessels. You can see it is superficial; it's not gone deep. See, you can see in this picture it is a deep one. So deep one shows a scleral inflammation, and superficial one shows it is a episcleral inflammation. Okay. How you differentiate between conjunctivitis and scleral inflammation is that in conjunctivitis it is always a branching one. You can see it's a branching one. While in a scleral or episcleral condition, you can see the blood vessels which is being moving towards the limbus. You can see the blood vessels being moving towards the limbus. Okay, but in this you cannot see in such a manner. Okay, so this is how you differentiate between conjunctivitis and episcleral or scleral inflammation. Now you have an examination of iris. The next part. The color, surface, synechia, nodules, neovascularization, and presence of any holes. So these are the colors that is there, which is usually exhibited for the iris. You have and the color of the eyes determine actually the beauty of the eyes. You have blue eyes, green eyes, black eyes, brown eyes. All those things are there, and that is all hereditary. You don't have anything to do with it. But what matters you is that you should see that the colors which whether is in the presence of in the iris, are there any presence of lighter colors or are there any presence of darker colors? This is what you have to see. So you can see in this picture there are some areas of light colors, and in this picture you can see some areas of dark colors. See, okay, so this is what you should make out, check out. See, in this you can see whitish areas, this whitish areas. Okay, see, you can see the whitish areas. Okay, and you can see here the presence of dark spots. Okay, this is what you should make out. Now, this is how a normal pupillary surface and iris surface look. Okay, so you can see the pupil. This is the pupil. The hole that is made is the pupil. You can see the collarete, the fascial area of this is the collarete. There is crypts. These are the holes is called as the crypts. This you can see in normal pupil. Normal iris. Now, what happens is that, see, in this picture, there are no collaretes, there are no crypts, everything has been lost, and iris appear in a muddy fashion. Okay, this is what is called as loss of crypt, and this is usually seen in iridocyclitis. Okay, now, or you can see in atrophy of iris, you can see some grayish areas, the hypo colored areas. Okay, this is called as, this is seen in atrophy of the iris. Okay. Now you can see synechia. You can see this is the lens which I have touched is the lens. Okay, and this is the iris. So iris has, you can see some fibrin cellulose, fibrin deposits that has been has occurred here, and the iris has been attached to the lens. This is called as synechia. What is the problem with such a type of synechia? The fluid which is coming from the posterior chamber will not be able to move into the anterior chamber, and there will be chances of iris bombay, that is iris being pushed forward, and then which leads to the glaucoma. Okay. Now check for the presence of nodules. Okay, the most important things what you need to understand is the presence of nodules. You can see either some nodules in the pupillary margin, which we call as Coppe nodules, or you can see them in the surface of the iris, which is called as Basaka nodules. So both these are usually seen in the inflammations of iris. Okay, and then you can see the either you can see some cyst, you can see iris cyst, you can see some iris cyst, or you can see iris mammillations. This is not very common presentation. Iris mammillations, you can see some elevations of iris, continuous all round geographical spread of the elevations, and or you can see some whitish spots. Can you make it out here? See, whitish spots. This is called as Brushfield spot, and you can find it in Down syndrome, Brushfield spot. Okay, now you can see even Lish nodules. You can see some brownish spots like this, Lish nodules, and this is very important. Lish nodules are seen in neurofibromatosis type 1, which we call it as von Recklinghausen disease. Okay, so this type of Lish nodules is seen. So you have to make out. So if you want to see some nodules, just try to understand whether it is due to any inflammation. If it is inflammation, it usually appears in the form of either Coppe nodules or Basaka nodules. Okay. Now holes or gaps in the iris also you can see. See, this is a natural gap that has occurred, which is called as coloboma of pupil. Coloboma pupil. Sometimes you can see an artificial hole that is being created. See, especially in people who are having a history of increased intraocular pressure. This is called as iridotomy, and usually we use laser, ND-YAG laser to create iridotomy. So iridotomy holes can be seen, or you can see when the iris is being, a part of the iris is being removed, surgically removed. So it's not a coloboma, but it's iridectomy. The iris is being removed. Okay, so you can see when iridectomy is happening. So check out for all these. So these two, the below two images, the two pictures show that there was the person has had an increased intraocular pressure. Okay. Usually the blood vessels on the iris cannot be seen, but in this case you can see the neovascularization of the iris. So neovascularization of iris always indicates that there is a retinal hypoxia. That is, the blood vessels in the retina are deficient in supplying the blood to the areas, and hence neovascularization has started. Now examination of pupil, the number, location, size, shape, color, and pupillar reaction. So you have a polychoria. Usually you have only one pupil, but there you can see multiple pupils in this. That is polychoria. Or you can see keratoopia. You can usually the pupil is placed at the center part a bit nasally, but if it is moved from there, it is called as keratoopia. See, you can see that it is not at the center. You can see that in this case the pupil is not at the center. You can see in this case the pupil is not at the center, so it is called as a keratoopia. Okay. Now you can see the size of the pupil. And normally pupil size is 2 to 3 millimeters or 3 to 4 millimeters, and then you can see a very small 1 millimeter size meiosis, and you can see a mydriasis. See, you can see this the entire eye is dilated. You can call it as a mydriasis eye. Okay, so this also you should check out. Okay. And then color of the lens. This is very important. So the lens, usually the lens is a transparent one, and then you can see the grayish white color of the lens, or you can see a pearly white color of the lens. Pearly white color is seen in mature cataract, and then milky white you can see in mature cataract. You can see jet black pupil. See how it is, jet black pupil in aphakia. You can see brownish color or blackish colors, both them are in cataract. Now you can see a particular thing which is called as iris shadow here. See, this is the iris shadow. Whenever you take impinge light from the 60 degree or 70 degree angle from the temporal side or nasal side, what happens is that this iris, it will be creating a shadow onto the lens in the form of a in the form of a semi-lunar appearance, which is called as the crescent appearance, which is called as the iris shadow. So this shadowing was called as the iris shadow. Okay. Now, shape of the pupil, you check whether it is a pear-shaped pupil, whether it is circular, or even you can see sometimes irregular pupil like this. Irregular pupil is always happening after an iridocyclitis or a uveitis, okay, anterior uveitis. Now, you check for the pupillary light reaction. you have two types of pupillary light reaction mainly, a direct light reflex and indirect light reflex, or a consensual light reflex. Direct is you put light on the eye and that eye gets closed, and indirect is you put a light on one eye and the other eye closed. Okay. Now there is something called as RAPD, that is a relative apparent pupillary defect, wherein when you put one light on one eye and then you shift the torch to the other eye, usually the other eye should also close. But in RAPD, what happens is that the eye will get open. That is, the pupil will get open. This is called as a relative apparent pupillary defect. Okay. And now you have examinations of lens, presence of absence of lens, pseudophakia, color of lens, deposits if any. These are the normal things that you should check on. See the picture which I told you, that is posterior chamber intraocular lens is rightly now practiced here. Okay. And then any deposits over the lens, you should check in Vossius ring. So you can see this is called as Vossius ring. This is usually happening after a trauma. So if any person complains of some hit over the eye with any ball or any hit, direct hit, check for the presence of any Vossius ring. Okay. Now, now we are coming to the last part of the eye, that is the retina, where this is a normal retina, where you have, as I told earlier, there is an optic disc. Where there is a macular area, you have a fovea, and you have a foveolar area. This is how a normal retina is. Okay. Now, for examining of a normal retina, you require an ophthalmoscope, whether it's a direct ophthalmoscope or an indirect ophthalmoscope, and that is actually costly. And it should be, there should you have an expertise to operate it. So you can actually order a fundus photograph from the eye from any ophthalmology institute, wherein you will get similar pictures of the eye. And then you can identify the retina. You can make out what are the changes in the retina. Okay. So you can see the examination of fundus. I'm not going into the details of all these things, the diagnosis of all these. What my basic aim is that to introduce you to these are the apparatus, these are the instruments, these are the areas you should examine. The disease and details can be only, it's not possible to take everything in one class. Okay. So please understand that these are the things which you can find out. See, there is an edema, or you can make out right there is an edema, or then this is actually a case of wet ARMD, where ARMD is age-related macular degeneration. Okay, so you can see the bleeding. So you can see some redness here, or it's bleeding is there, edema is there. All these changes you can see. Okay, or you can see in such fundus photograph where you can see some yellowish areas here. Okay, these are the hard exudates. You can see some red areas, retinal hemorrhages, and you can see some white areas, which is called as the cotton wool spots. Okay. And you can see that actually here in this the optic disc margin, it is actually blurred here. Okay, you can see you cannot make out the margin, but in the in the previous picture you can see the optic disc margin. So you should even check out for the optic disc margin whether it is blurred or not. Okay. Now see, you can see here hemorrhages. See, you can see the hemorrhages. You can see even the hemorrhages here. See, you can see the hemorrhages. So you can check out whether there is hemorrhages or not. And you can see even retinal degeneration. See, in the peripheral area, there is blackish degeneration that is happening. It's retinal degenerations. You can see some edema. See, can you make out the change here? Can you make out the change? You can make out macular edema. You can see that entire retina has been detached off, and it has come through like this pictures. So you can see the presence of retinal detachment. Okay. And in this picture, I would like to make you understand one more point. See, in this optic disc, there are two parts. This is the optic cup, and this is the optic disc. Okay, so usually in glaucoma, we check for the ratio of the optic cup to optic disc. So we call it as cup disc ratio, which we check. Okay. Now you can see such kinds of spots in people who have already taken lasers. In nowadays, that is being increased more and more because of the diabetic retinopathy cases, increased diabetic retinopathy cases, and more laser photocoagulation that is being taken. So you can see laser scars. In this, you can see this is a typical presentation of retinitis pigmentosa, where you can see the bony spicule presentations. You can see the bony spicule presentations. Okay, you see this is exactly a bony spicule presentation, retinitis pigmentosa, and you can see even the optic atrophy here. The optic disc, the optic nerve has been optic nerve head has undergone consecutive optic atrophy. Okay. Now you can see a primary optic atrophy here. You can see a chalky white primary optic disc atrophy. You can see the degeneration that is here that has happened, and then you can see a secondary optic atrophy that has happened here. It's yellowish. Okay, waxy yellow. Okay. Now you can see in this picture, you can see there is a macular scar that has happened. See, macular scar. You can see when the lines, the pulling lines here, you can see the macular scar that has happened here. Macular scar because of some hereditary macular diseases. Macular scar has happened. Okay, and you can see in this you can see a crescent. You can see a crescent in this. This is usually seen in myopic people, which we call it as myopic crescent, or you can see even sometimes you can see it's a peripapillary. In peripapillary, it happens in glaucoma. So glaucoma also you can see peripapillary crescent. Okay. Now you can see the tortuosity of veins that is happening. Whenever there is a tortuosity, you can understand that there is some blockage. So central retinal vein occlusions or venous occlusions is the cause. Now, after the retina, there is intraocular pressure, which is measured either digital, Schiort's applanation of contact, non-contact tonometry. Digital is very simple. You apply two index fingers on either side of the eyeball and press one eyeball and feel the pressure, but it requires expertise to understand what is the pressure. Schiort's tonometry, you might have all seen in your graduation, where you use the Schiort's tonometer to make the pressure, to understand the pressure of the eye, to measure the pressure of the eye. And this is a tono pen, but this is very costly. Even if the instrument is like this, it's around 75 to 80,000 rupees. You can use even a tono pen. And this is the gold standard one which we use, applanation tonometer. And you can use even non-contact type tonometer, where there is no contact, but air puff is being given for measuring the intraocular pressure. Okay. Now let us go into the OCT, which is a very advanced and commonly used right now instrument, optical coherence tomography, which is a non-invasive tool that is used to understand the maculo-optic nerve and the retinal nerve fiber layer. So basically, you can see such kind of investigative report that the people are bringing, and this area, which is depression in the macula and other areas the nerve. OCT is again a very vast area which we need hours to speak up. But right now, I'm only giving you a brief idea what OCT is. You can see this for the people who are interested. You can see the layers of the retina that you can see on OCT. I've just put into this, and based upon the layers of retina, the diagnosis can be made. On a grossly, I'll get you some idea. See, you can see there is a discontinuation of the retina. So this is a full thickness macular hole that is there, and you can see even some cystic spaces that is here. Okay. You can see edema because this is enlarged, this is elevated, there is an edema, and you can see the entire RP has been elevated, so there is edema below. From the choroid, the edema has been coming, so it is a wet ARMP that is happening. Okay. So you can see some cystic spaces here. So there is a fluid-filled cystic spaces. You can see there is a pigment epithelium detachment here, and the pigment epithelium is attached here, and there is a seral retinous detachment here. So you can make out this one. Okay. And then you can see some blood exudate, that is local blood bleeding that is happening here. And when there is a blood, there is a shadowing effect. You can see the shadows that is coming here. Okay. And in this case, in this picture, there is a massive pre-retinal hemorrhage, and you can see that there is a massive bleeding that has occurred in this. Okay. So to understand the basic, it's a massive subretinal hemorrhage, not a pre-retinal one, it's a subretinal hemorrhage, because you can see it's inside the retina, Okay. So you can see the hemorrhagic pattern that is there. Okay. Now, you can even understand the OCTs of retinal nerve fiber layer, which is very useful in identifying the glaucomatous pattern. Again, here I would like to show you that the more the area is going towards the yellowish colors, that means the thickness, the more the area that is present in the green color, you have to see in this area. Okay. So the area, the more it is in the green color, the thicker the retina, and then the more it comes to the yellow and red, the the thinner the area. Okay, so the quadrant has been divided below. You can see the temporal, superior, nasal, inferior, and you can check out for whether the retinal thickness has been decreased or increased after your treatment, so that you can check. This is called as retinal nerve fiber analysis. Okay. And for the people who for checking a CD ratio, you can even see the CD ratio here. See average cup disc ratio, CD ratio. You can use an average CD ratio as 0.72 for the OD. OD is right and OS is left one. Okay. So that also can be used. That also can be examined using the retinal nerve fiber layer. Now this is from the forgot to delete this slide. This is for the iris changes which has been shown earlier. Okay. Now fundus fluorescein angiogram. This is also one more investigation that we use. This is just like the coronary angiogram which we use for measuring for seeing the nature of the blood vessels of heart arteries, coronal arteries. Similarly, for the nature of understanding the nature of the retinal arteries, we use and retinal vessels, we use fundus fluorescein angiogram. It is contraindicated in retinal impairment and non-fluorescein through allergy. That's very important. So what is it's a very vast area. The most important point what you should know is hypofluorescence. Hypofluorescence means you can see the areas of decreased fluorescence. So you can see here, you can see here, you can see here. All these are areas of decreased fluorescence. Decreased fluorescence determine that there is some block for the passage of blood. There is hypoxia. So that area will be having some defects of the defective blood supply. Check out for the presence of hyperfluorescence. See, you can see here hyperfluorescence. 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 You can see here hypofluorescence. So that area means there is excessive fluid loss, or there is excessive blood being collected to that area. So that means there is a Vimarga that is happening. So one is a Srotoroda and other is a Vimarga. So based upon this, you can use the FFV. Now next is an electroretinography, which we use for the functional assessment of the retinal pigment cells. Where in a normal eye, the most important point is the B wave. So you have to see if the B wave is flattened, it means that there is diseases like retinal pigmentosa, which is affecting the rods and cones. So you can see here, see the amplitude and latency. This is latency means which is the time which is taken, and the amplitude means the height of the wave. So decreased amplitude and decreased latency suggests that there is diseases like retinitis pigmentosa. Visually evoked potential. Visually evoked potential is usually for understanding the nature of the impulse that is being shown in the visual area or the cortex. And the most important one is the P100, the P100 one which is showing. So you can see that the P100, if the latency is increased and if the amplitude is decreased, there is a glaucomatous changes that is occurring. That is what, not only glaucomatous changes, there is changes in the correct amount of light is not being, information is not being transmitted through the optic nerve to the visual area for understanding what is the impulses that are being there, or what is the image that is formed. That is why visual evoked potential is being used. Okay. Now, coming to the last item, there is the B scan which is there, which is actually used in conditions where you cannot examine the eye. The entire cornea is being degenerated. You have an opacity, you have total cataract. You want to understand what is the nature of the retina. Then you go for a B scan. It is actually an ultrasound scan. So you can see an ultrasound. You can see the lens, you can see the vitreous, you can see the optic nerve. This is the optic nerve. Okay, and you can see there is a detachment of. You can see some detachment here. This is called the retinal detachment. How you identify retinal detachment is that it is attached to the optic nerve. This is the optic nerve. Okay, so there is an attachment to the optic nerve, and in this case, you can see there is a posterior vitreous detachment. See, there is no attachment. There is a posterior vitreous detachment. Okay. Now there is a vitreous hemorrhage that is there. You can see some kind of. You cannot confirm this whether it is a vitreous hemorrhage or not from only from this scan. You require a clinical examination also, but you can get some idea that there is some kind of opacities there in the vitreous. You can see some kind of intraocular tumors also here. See, so all these kinds of changes can be taken from the D scan. So D scan is used to see the posterior retina. Okay. So coming to the last area, the most important this is self-explanatory. I just made into a chart so that people, graduates can use this and practitioners can use this in their normal area. There are two types of vision loss. There is a defective vision or a loss of vision. And this is self-explanatory, how you come to an arrival, what is the cause of the vision. Okay. And you have a transient loss of vision. That is, sometimes the vision will suddenly get lost and the person will regain the vision, which can suggest either a migraine, severe hypertension, or an intracranial hypertension, which is causing a papilledema. I think papilledema was explained in the last class by Dr. Sri Kumar. Okay. Then in night blindness, you have vitamin A deficiency or retinitis pigmentosa. And day blindness, that is in daytime difficulty in seeing, it can be in a polar cataract. So you see, this is a polar cataract, or it can be central corneal opacity. In the center of the cornea, there is an opacity. Floaters or black spots that appear in the eye can be either due to vitreous hemorrhage, exudates, vitreous degeneration, or lenticular opacity. And in the flashes of light, this is very important. Whenever the patient complains of flashes of light, suspect for a retinal detachment or a vitreous detachment, tractions, or any migraine. Migraine is the last one. Distorted vision is usually seen in severe astigmatism, central serous retinopathy, age-related macular degeneration. So what you use is a Amsler grid. You keep an Amsler grid in front of the person at an arm distance and ask the person to see there is a line, whether there is a bending of any line. If there is bending like this, that means it's a distorted vision. Okay. Now the last one is the glare and photophobia. Glare and photophobia, it's the glare is seen in the early cataract and corneal edema, and photophobia in corneal abrasions and acute conjunctivitis. Okay. So with this, I humbly would like to end my presentation on the basic examination skills and the parts which you should examine, what all presentations you could see in your patient. So that the investigations that you can use and the reports how you need to interpret so that you can use in a normal clinical practice. With the humble message of Loka Samasta Sukhino Bhavantu, I would like to end my presentation. Thank you once again, Ayurveda Math, for providing me this opportunity. Thank you.
Thank you so much, sir. And to all the attendees, if there is any question or doubts regarding the session, you can message it in the chat box.
Sir, I congratulate for this wonderful lecture. Myself, Dr. Himang Shah. I am working as eye surgeon and doing Ayurveda in Netra Chikitsa since 10 plus years. And my father is also ophthalmologist, and his name is Dr. Chotalal Shah. He was practicing in Mumbai. So he also heard some of your in between the lecture, and it was very nice. In my times, there were no one to explain in such a detail and such a proper manner whatever you told today. So I congratulate. Thank you, sir.
Thank you, sir, for the feedback. And sir, Praveen sir, there is a doubt in the chat box. I'll read it out for you. What are the conditions where dilatation should not be done?
What are the conditions where?
Dilatation should not be done. Dilatations. Hello? Is it audible, sir?
Yeah. So, it's audible. Am I audible?
Yes, you are audible, sir.
Okay. Am I
What
audible?
are the conditions?
Yeah, okay.
Yes, sir, you are audible.
Yeah. Okay.
What are the
So,
conditions
basic
where dilatation?
Hello?
Yes,
Hello.
sir. Yes, sir.
Yeah, okay. So, yeah, I got your question. I would make it in a very simple manner. See, what happens when you are doing in a dilatation is that you are shrinking the entire iris towards the sclerocorneal junction. So what happens is that there is a greater chance of increase of pressure of the eye. That is greater chance of getting narrowing of the anterior chamber. So any condition which will ignite a person into getting a complication of increased intraocular pressure, all those are contraindicated for dilatation. This is in very simple sense I can explain. So the first most important disease is obviously glaucoma. Whether he has a history of glaucoma or is there any hereditary conditions of glaucoma, you should be extremely careful enough to make sure that the person, if he gets dilated, does not have an increase of intraocular pressure, so that it will not get a trigger of glaucoma. That is the most important point that you should keep in your mind. Hello?
Yes, sir. Hello. Thank you, sir.
Yeah.
Sir, another question is that, sir, in cover and uncover test, if we remove the cover from the eyes, then can we see the squint after removing the cover, or otherwise also we can see it? How does it actually work, the cover and uncover test?
No, it is actually the test is based upon the dominant eye and based upon the suppressed eye. This is how the test is being usually interpreted. Okay. So it's a bit advanced one. That is why I did not go into the depth of it. So what happens is that, suppose you have both of your eyes normally working, and as I mentioned earlier, for the stereoscopic vision, the brain gives the power to both eyes equally. It takes the images from both eyes in equal manner, joins them, fuses them together, and then the image is being reconstructed and shown into the eyes. Okay. So what happens in squint is that, or if you have a latent squint is that, or if you have a suppressed eye, what happens is that one of the image from the eye will be obscured, or which is not being shown into the, projected into the brain. That eye will get suppressed and only one eye will act as a dominant one. So what happens is that when you cover one eye, if it is dominant, it will take up when the other eye is covered. And if it is not dominant, it will not take up. This is how. So I've given actually one description, that is there are 3 or 4 slides which is giving an exact description of how to interpret the dominant eye and the non-dominant eye. You can go through that, and that will make your doubts clear. Because actually it's an advanced one. That's why I just left it out. Okay.
Okay, thank you so much, sir. And so there is one more thing, that what is the actual normal value of A scan?
Textbooks and theories show that they are around 24 mm. Okay, but hardly you find around 24 mm. You will not get it. So what the range which you find it in the clinical databases is like they go from 21 mm to around 26 to 27 mm. That is what you get in clinical databases. And that's not there in theory textbook. Again, I mentioned I would like to take the point. In theory textbook, it is 24 mm, and hardly you will not you will get for 24 mm. I think Hemang sir and others who are eye surgeons, they can answer this much better, because they routinely take up for a scan for of the people. Hello?
Hello? Yes, sir. Thank you so much.
Yes, sir.
And
it is around 24.5 mm, nearly.
thank you, sir. Thank you, Hemam sir. And sir, can you please explain us the mechanism of eclipse test?
Eclipse test is very simple. You can just take the torch, bring it to the perpendicular to the sclerocorneal plane, or just a bit 10 degrees apart from it. Project the light onto the temporal area. You can see both sides, that is temporal half and the nasal half of the cornea, not cornea, the iris being illuminated similarly. If it is illuminated similarly, it means that the anterior chamber is not shallow or it is normal. And if you see any kind of shadowing on the nasal area or on the opposite area of the applying of the light, source of light, it means that the anterior chamber is shallow. So, and the picture which I had shown you regarding the shallowing of the anterior chamber, you can use also even that also to make yourself clearer whether it is the AC is shallow or not. That's all.
Thank you, sir. Thank you so much. And there is one more question, like, is placidosis enough to see curvature of cornea at OPD level?
It's like if you have a gross changes, you can easily make it out. But for the fine changes, you cannot do that. The pictures, whatever describing regarding the placido's ring, are not actually from a normal OPD placido, but they are from the orb scan which we use. Hello?
Thank you, sir. Yes, sir. Thank you so much. Thank you so much, sir. And I think almost the questions are and queries regarding the sessions are almost over. If there is anything else, kindly please post. We are concluding the session. Thank you, sir. Thank you so much. It was really a wonderful session. And it is like, and so there is like one query that there was a voice break regarding the macular fibers. So could you please explain that part a little? One of the attendees has asked that macular fiber area, it was a bit breaking. The voice was breaking.
No. What is the thing you need to know on the macular fiber?
Just a minute, yes, sir. So that was regarding we visualize the macular fibers, no? Regarding that portion.
In the initial anatomy part?
Yes, anatomic part.
Okay, just a minute. I think then I will have to show the slide because then only that will be easy. Okay, so see this slide shows the arrangement of the macular fibers, papillomacular bundle and the other retinal nerve bundle. That this arrangement should be kept on your minds, because this nature of the arrangement of fibers is important for the suspicion of your disease. Because see, you can see the macular area, the macular fibers.
Sir, hello?
In the optic nerve. Pardon? Yeah, please.
Sir, the screens are not shared. Your screen is not shared.
Okay. Okay, just a minute. Now is it visible?
Yes, sir.
Hello? Yeah. Okay. So in this, you can see this picture. There is the papillomacular bundle. The nerve fibers are arranged here. So you can see in this area, which I have touched. Okay. And then these fibers, when I'll just go into the. Okay. When these fibers, when they are in the optic nerve head, that is in this area, the optic nerve head, you can see the macular area, which is the macular fibers, they are more or concentrated towards the temporal area. Then you have the upper temporal and the lower temporal area. And as they go inside, that is, as they go inside the optic nerve, you can see the macular fibers coming towards the inside and the other areas being circulated around the macular area. Okay. Now the importance is this is mainly in the area of glaucomatous optic dystrophies or optic nerve diseases, where, as I mentioned, there is a particular fashion for the loss of the optic nerve, that is optic nerve functions, that is INST, that is inferior, nasal, superior and temporal. So what happens is that in glaucomatous area, in glaucoma, as the diseases advance, first there will be the lower temporal quadrant will be having problem. Then the nasal area will have problem. Then you have the superior area will have problem, and lastly the temporal area will have problem. That is, whenever the temporal area is having issues, that is only at the last moment. So you can see in the earlier picture, the above picture which I have shown here. Just a minute, I'll just go into the presentation mode. Yeah, okay. So you can see in this, the fibers which are in the innermost are here. Okay. And as it goes inwards, that is, as fibers come and more fibers come here, they will be going into the interior. So the most interior part will be preserved. That is why we have seen earlier in this picture. See, so you can see in this picture, there will be central vision will be preserved and the peripheral vision will be lost in glaucoma. The reason for is this is the arrangement of this papilomacular bundle and the other arcuate bundles in this fashion. This is the reason why there is a special field of the peripheral loss and preservation of central vision is being maintained. Okay. Hello?
Yes, sir. Thank you so much. That's enough, sir. That was the area where it was lost. Thank you so much for taking such a wonderful session. It was really a very highly explanatory and detailed session. Especially, it will be of high beneficial to those people who are specialized in eye-related treatment. That is Shalakya itself. Those PGs who are doing Shalakya also. For them, it will be highly beneficial. Thank you so much for being a part of the session. And thank you for all the efforts that you have taken to.
Thank you, sir. Thank you very much.